Good morning, everyone. Our topic today is about sleep disorders in palliative care and pain medicine. Incidence of sleep disturbances can be defined as any symptom or condition that interferes with normal sleep. They are very common in patients with advanced cancer, with the prevalence reported to be between 24% and 95% in this population. However, this problem is usually neglected in treatment strategies for advanced cancer, as many studies have focused on patients with early stage disease and on survivors. Sleep disorders are a group of pathologic conditions that have been defined based on clinical presentation and diagnostic criteria. There is a classification system published by the American Academy of Sleep Medicine, the AASM, that standardizes the diagnosis of sleep disorders and is especially useful in the research setting. The system recognizes six major sleep disorder categories: insomnia, sleep related breathing disorders, hypersomnia, circadian rhythm sleep disorders, parasomnias, and sleep related movement disorders. Of those disorder categories, the most common in advanced cancer patients compared with the general population is insomnia, which accounts for 35% of the diagnosis in these patients. Again, this is the classification here. In our presentation today, we'll be focusing on certain topics, mainly the insomnia disorder, the breathing-related sleep disorders, and restless leg syndrome. Insomnia is a complex complaint that can be defined as difficulty initiating sleep, trouble staying asleep, with prolonged nocturnal awakenings, early morning awakening with inability to resume sleep, or impairment of daytime functioning. Insomnia can appear as an isolated disorder or as a symptom that accompanies a different disorder. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, and the International Classification of Sleep Disorders, 3rd edition. Insomnia's diagnostic criteria are similar because of collaborative efforts between the American Psychiatric Association and the AASM classification task forces. The DSM-4 distinction into primary and secondary insomnia is removed in the DSM-5. Daytime distress or impairment in work, family, academic, and other vital areas of functioning account for another key component. Other symptoms that commonly accompany insomnia include mood disturbance and irritability, inertia, and especially in children, behavior problems, such as hyperactivity, impulsivity, or aggression. ICSD-3 and DSM-5 both distinguish between short-term and chronic insomnia, with the latter continuing for 3 months or longer. Prevalence. The prevalence of sleep disorders in cancer patients is about twice that in general population. Screening tests used for sleep disorders are heavily weighted toward diagnosing insomnia. Therefore, it is not surprising that most common sleep disorders found by the palliative cancer patients uh, by in palliative cancer patients were difficulty falling asleep, accounting for 40%, difficulty staying asleep, 63%, and not feeling rested in the morning, 72%. Adjusted insomnia, acute insomnia, and insomnia due to medical conditions, comorbid insomnia, are the most common new onset sleep disorder subtypes. The prevalence of sleep disorders varies depending upon the type of cancer. For example, breast cancer patients have a high frequency of insomnia and fatigue, whereas lung cancer patients have the highest prevalence of sleep disorders in general, owing to coughing, difficulty breathing, and nocturia that lead to frequent awakenings that disrupt the patient's sleep pattern. Normal sleep architecture. The normal sleep physiology has been divided into two physiologic types: the REM or the rapid eye movement and the non-REM or non-rapid eye movement sleep. The latter is subdivided in stages numbered from N1 to N3. The last stage is known as the slow wave sleep based on electroencephalography. Perhaps the most important difference between the non-REM and REM is the presence of voluntary muscle paralysis with the evidence of electroencephalographic activity in the REM sleep. So patients that are in REM sleep, they have basically voluntary muscle paralysis. And this is the period where all of us experience dreams. And there's also significant autonomic variability. Um, so I'm gonna go directly to show you the picture here. So this is the sleep cycle. It's like around 90 to 120 minutes. You have the non-REM, which is basically divided into three stages: stage 1, 2, and 3. And then you have the REM sleep. Okay. So in stage 1, we experience a light transitional sleep. This is where drowsiness starts and sleep begins. Stage 2, more stable sleep occurs. Chemicals produced in the brain block the senses, making it difficult to be woken. Stage 3 is the deep sleep, where you have the growth hormone released during the stage. Most stage 3 sleep occurs in the first third of the night. The REM sleep is the one that revitalizes the memory. This is where you have this voluntary paralysis and dreams and autonomic variability. So we'll start with the insomnia. As I said, we'll be focusing on three topics today. All right, the others we're gonna go through them pretty quickly. One of the most important ones that we encounter in palliative setting is the insomnia. And we have different types of insomnia. We have the adjustment insomnia, we call it acute insomnia. We have the psychophysiological one, we have the paradoxical one, we have idiopathic insomnia, we have insomnia due to mental disorder, we have inadequate sleep hygiene, we have behavioral insomnia of childhood, we have insomnia due to drug or substance, we have insomnia due to medical condition, we have insomnia not due to substance or known physiological condition or unspecified NOS, not otherwise specified. And then we have physiological insomnia. The insufficient sleep has a deleterious effect on your body here, starting from distractibility to poor attention span. to poor organizational skills, to poor motivation, irritability, easily frustrated, depression, anxiety, and defiance. General criteria for insomnia: difficulty initiating sleep, difficulty maintaining sleep, or waking up too early, or sleep that's chronically non-restorative or poor in quality. Sleep difficulty occurring despite adequate opportunities and circumstances for sleep. Patient reports at least one of the following forms of daytime impairments related to nighttime sleep difficulty: fatigue or malaise, attention, concentration or memory impairment, mood disturbance or irritability, daytime sleepiness, motivation, energy or initiative reduction, proneness for errors or accidents at work or while driving, tension, headache, gastrointestinal symptoms in response to sleep loss, concerns or worries about sleep, sleep-related breathing disorders, such as central sleep apnea syndromes, obstructive sleep apnea syndromes, and others. We'll focus on snoring and sleep apnea. Obstructive sleep apnea, uh, you know, can lead to multiple serious side effects and complications, starting from high blood pressure, increased insulin resistance, increased traffic and workplace accidents, can lead to hormonal disruption, stroke, memory problems, snoring, cardiac problems such as abnormal heart rhythms, heart attack, and heart failure, and lastly, depression. Sleep apnea is a breathing disorder that causes repeated lapses in breathing during sleep. Obstructive sleep apnea occurs when the upper airway becomes blocked, leading to brief pauses in breathing during sleep. Symptoms of sleep apnea can include snoring, headaches, and excessive sleepiness. Treatment options often involve CPAP therapy or positive airway pressure therapy and lifestyle changes to reduce symptoms. Sleep apnea symptoms starts with the snoring, insomnia, and then snoring, dry mouth, morning headache, memory loss, attention deficit, depression, fatigue, nocturia, and impotence. One of the ways to deal with sleep apnea, obstructive sleep apnea, to use this dental device. Of course, this has to be done through your dentist here. Then we have the non-invasive posture pressure ventilation. And these are two types, the CPAP and the BiPAP. Okay. Most patients will need, with obstructive sleep apnea, just need the CPAP. But if the CPAP is not effective in removing the CO2 in your body, then probably you will need the BiPAP. Okay, so that's the BiPAP is a little bit more advanced than the CPAP as far as the ventilation and having more control on your breathing at night than the CPAP. The CPAP is a kind of just giving you this push, this positive pressure at night, so your airway doesn't get blocked. But the BiPAP actually helps you with your ventilation. So if you have really a high CO2 that needs to be removed, you're probably going to need the BiPAP. And I mean, as far as the machine goes, they look like very similar to each other. Again, this is a difference between CPAP and BiPAP. Uh, we have here also the high flow, but this picture is basically reviewing all the non-invasive ventilation, you know, methods, and comparing them together. Uh, as far as our presentation goes, the most important ones you need to know about is the CPAP and the BiPAP. And as you can see here, the CPAP, one of the indications here is the hypoxemic type 1 respiratory failure, while the BiPAP is type 2, the hypercapnic. Remember, we said that with the BiPAP, you it helps you with removing the CO2. And this is basically how to, start your settings here, including the FiO2 and also the CPAP level, which is analogous to the PEEP here. And then here you have the inspiratory level, typically between 7 to 20 millimeter water, and the expiratory, the EPAP level, typically between 3 to 15 millimeter water. And your FiO2 is again between 20 and 21 to 100%. So with the BiPAP, you need to adjust two levels here: the IPAP, the inspiratory limb, and the EPAP, the expiratory limb. The expiratory limb is the one that's similar to the CPAP. Okay. All right. Then we have another condition, which is the hypersomnia, and this, there are many variants. We're not going to go through all of these, but just remember the name, the most important names, like the narcolepsy with cataplexy or without cataplexy, for example, or narcolepsy due to medical conditions. So what does narcolepsy looks like? Well, these patients, they have excessive daytime sleepiness. They have something called sleep paralysis. They have disrupted nighttime sleep. Sometimes they have hallucinations, and they have a cataplexy. Unfortunately, only 25% of Americans are diagnosed with narcolepsy, have been diagnosed correctly and treated. This is how a narcolepsy patient look like as far as his sleep goes. As you see here, this is a healthy sleep, awake sleep, and you get interrupted here, some awake, but with narcolepsy, it's really a kind of, very random here. And this is the biggest problem with, narcolepsy. You can sleep at any time of the day. Okay, circadian rhythm disorders. Again, we're not going to focus on these, but just remember the names. I want you to learn the names because one of these days you will encounter these cases. All right, so we're not going to go into details about them. We have different types like circadian rhythm disorder with delayed sleep phase type. We have one with advanced sleep phase type and others. Like the one that most of you guys are acquainted with is the circadian rhythm disorder with the jet lag type. Okay, I'm sure all of you guys experienced this during your traveling here. So to simplify the circadian rhythm disorder, during the day, your nucleus raphe releases serotonin because you get exposed to the sun, okay? And this will awaken you. While at night, your pineal gland will release a very important hormone called the melatonin. And the melatonin is the one that helps you go to sleep sort of. This is very oversimplified, a picture for, the circadian rhythm disorders. Of course, the real disorder is, you know, um, basically it looks something like exactly like this. Okay, um, and thus, it really disrupts your daily activities. Um, there basically we don't have a cure to circadian rhythm disorders. However, we have some medications that can help out, restoring this normal circadian rhythm, such as melatonin and others. We're going to talk about them later on. Parasomnias. Again, another important topic, but is out of the scope of this presentation. Disorders of arousals from non-REM, and we have parasomnias associated with REM sleep, okay, such as nightmare disorder, recurrent isolated sleep paralysis, and then we have other types of parasomnias, such as enuresis, for example, and others. So what is the sleep paralysis? We keep repeating the same words here. So sleep paralysis is identified by a brief loss of muscle control just after falling asleep or waking up. 75% of sleep paralysis episodes involve hallucinations. And then we have different types of hallucinations, like intruder hallucinations, vestibular motor hallucinations, and chest pressure hallucination. Like in the intruder hallucinations, it involves the perception of a dangerous person or presence in the room. The vestibular motor includes feelings of movement or out of body sensations. And lastly, chest pressure hallucinations, uh, it incites a feeling of suffocation. Sleep movement disorders. We have restless leg syndrome, and there's another one similar to restless leg syndrome, and a lot of people get confused about it. It's called the periodic limb movement disorder. We're going to talk about the restless leg syndrome in this presentation because it's really a common finding, and also you have to get like one or two questions in your boards regarding this restless leg syndrome. So you need to be aware about it and aware about the treatment. So restless leg syndromes, it happens at night, usually when you go to bed. You start to have this feeling of pulling, feeling like an electrical current in your legs, itching, aching, throbbing, and sometimes sensation like bugs are crawling under the skin. Restless leg syndrome is a condition that causes an uncontrollable urge to move the legs, usually because of an uncomfortable sensation. It typically happens in the evening or nighttime hours when you're sitting or lying down. Moving eases the unpleasant feeling temporarily. Restless leg syndromes, also known as Willis-Eichbaum disease, can begin at any age and generally worsens as you age. It can disrupt sleep, which interferes with daily activities. Management of restless leg syndromes. Address contributing factors such as anemia and iron deficiency, medications such as dopamine antagonists, antidepressants, calcium channel blockers, and opioids. Consider non-pharmacologic management. First, such as a trial of abstinence from stimulants, such as caffeine and nicotine and alcohol, a trial of mental alerting activities, such as video games, to reduce the symptoms at times of boredom, promote good sleep hygiene, uh, and if realistic for the patient, aerobic exercise, walking, and or stretching and intradialytic aerobic exercise. As far as pharmacologic therapy, right now, the first line is the gabapentinoids, such as gabapentin and pregabalin. And then, if this doesn't work, we have second line options, such as ropinirole or rotigotine, transdermal patches. And these are basically dopamine agonists. Gabapentoids, I mean, as far as a dosing, you don't need more than 300 milligrams as far as the gabapentin, and as far as the pregabalin, around 75 milligrams. Ropinirole starts from zero point 0.5 to 2 milligram, and then you have the rotigotine transdermal patches, which basically, uh, 2 milligram every 24 hours. Isolated symptoms, apparently normal variants and unresolved issues. This is the number 7 in the classification of sleep disorders, like long sleepers, short sleepers, snoring, sleep talking, and others. Other sleep disorders, number 8. I put the classification as it is because I wanted you just to have a broad idea about different sleep disorders. But as far as we're concerned in palliative care, the focus is basically insomnia, obstructive sleep apnea, and restless leg syndrome. These are the three main topics that you need to be uh, you know well versed about them, uh, because you're gonna see them in your daily practice. Number two, they definitely will be part of your board exam. All right. Doing some investigation includes sleep study. I've done one of these. It's it's a sophisticated test. They they have you hooked up to many wires to monitor your electroencephalogram, and also they attach EKG monitoring, and also pulse ox and all of that, and they really like monitor all your vitals while you're asleep, and so they can get a good idea about what's going on with you, during your sleep hours here. There is a very important index called the Pittsburgh Sleep Quality Index, which is basically it's a self-report questionnaire that assesses sleep quality over 1 month time interval. The measure consists of 19 individual times, creating 7 components that produce one global score and takes 5 to 10 minutes to complete. Developed by the researchers at the University of Pittsburgh, the PSQI is intended to be a standardized sleep questionnaire for the clinicians and researchers to use with ease, and is used for multiple populations. So basically, the PSQI, it's a questionnaire, self-report questionnaire, and it has been found to be reliable and valid. You don't have to remember all of these, items. However, the importance is to remember the name of the questionnaire itself. So these are the 7 components here: the subjective sleep quality, sleep latency, sleep duration, sleep efficiency, sleep disturbance, use of sleeping pills, daytime dysfunction. And then you do your calculations basically. Pittsburgh Sleep Quality Index. Another important questionnaire is the ESAS, the Edmonton Symptom Assessment Scale, developed by Dr. Eduardo Barrera. Um, Basically, Edmonton is a city in Canada, and that's why he called it after the place that he was working at. Anyway, the ESAS represents one of the first symptom batteries in palliative care, and has since been validated by multiple groups, translated into over 20 languages, and adopted in both clinical practice and research to support system assessment in many centers worldwide. ESAS was initially developed by Barrera et al. As a clinical tool to document symptom burden in patients with advanced cancer admitted to a palliative care unit. To date, many permutations of ESAS exist. The version used by the supportive care team at MD Anderson Center consists of 10 times with sleep replacing other symptom, and ask about the average symptom intensity over the past 24 hours. So this is the new version, guys, of the ESAT. And you can see there on the bottom. I brought this they because they actually they added the sleep to the questionnaire, and it's you can find it in the bottom of the ESAS here. This is very important, change that they made, and this kind of signifies the importance of sleep, in palliative care setting. Okay, management of sleep disorders. Um, Sleep disorder has negative effects on the quality of life, as we mentioned before, in patients suffering from advanced cancer and other diseases. Um, Management of underlying pathology is of a paramount in order to lessen the somatic, psychological, and social effects of sleep disorders experienced by cancer patients. Symptoms such as fatigue, impaired daytime functioning, and mood disturbances are commonly reported by advanced cancer patients and could be secondary to sleep disorders. Therefore, the development of interventions aimed at improving sleep disorders can help alleviate these symptoms and increase patient coping capacity. A multimodal approach with pharmacological and non-pharmacological interventions has been used to treat sleep disorders in advanced cancer patients, but data on the effectiveness of these measures in this specific population are limited. Although there are no prospective studies that inform an evidence-based approach, for many patients, a combined approach is most helpful. Non-pharmacologic interventions. Guys, this is extremely important, okay, especially in your exams. They're going to ask you this. Always start with non-pharmacologic intervention, okay? The first line of treatment is non-pharmacologic, all right? Don't jump on medications. So this we have like 10, uh, 10 techniques here into non-pharmacologic, interventions here. Number one, Maintaining a regular bed and wake time schedule. Establish a regular relaxing bedtime routine, such as soaking in a hot bath or reading a book. Create a sleep conductive environment that's dark, quiet, comfortable, and cool. Sleep on a comfortable mattress and pillows. Use a bedroom only for sleep and sex. Finish eating at least 2-3 hours before your regular bedtime. Exercise regularly. It is best to complete your workup at least a few hours before bedtime. Avoid caffeine close to bedtime. Avoid nicotine. Nicotine is also a stimulant. Okay, so avoid caffeine and nicotine, especially when you're getting close to bedtime. Also, avoid alcohol close to bedtime. So avoid caffeine, nicotine, alcohol, and your eating should finish at least 2-3 hours before your regular bedtime. Okay, one of the effective psychological methods that can be used in a patient with sleep disorder is cognitive behavior therapy or CBT. CBT is a supportive counseling intervention aimed at eliminating factors associated with chronic insomnia, reducing the severity of perpetuating factors below the insomnia threshold, and deactivating the hyperarousal. Importantly, two meta-analyses reveal that some of these interventions might have efficacy against insomnia. Uh, I, I want to mention something that CBT is conducted by a certified psychologist. Okay? So this is something that you need to bear in mind here. Cognitive behavior therapy, basically, what we think affects how we act and feel. It's a connection between three uh, main issues here: the thought, the behavior, and the emotion. These three are interconnected to each other. So, to change your behavior, you have to change the thoughts. And then, if you want to change the emotion, you have to change the behavior. Complementary therapy. Complementary therapy intervention has been tested, including progressive muscle relaxation, which decreased sleep uh, latency in patients with multiple cancers, hypnosis interventions, which decreased hot flashes in breast cancer patients, and bright light therapy, which might improve sleep disorders and fatigue in breast cancer patients during chemotherapy. Exercise interventions such as stretching, concentrating, and strengthening affect the circadian. Regular exercise for a sustained period of time may help to improve sleep latency and quality. Although not all the studies found benefit from combining specific interventions, layering different approaches appears to be helpful, or at least some patients, and they are all of low risk intervention. So, one of the most important ones is the hypnosis. Hypnosis is an awake state of relaxation, imagination. It's an exercise of your mind, rapport with your unconsciousness, and the ultimate display of control. Progressive muscle relaxation is also another way to help with sleep. Bright light therapy, pharmacologic interventions. All right. Pharmacotherapy is the most common interventions, in sleep disorders, especially in cancer patients. The newer short-acting benzodiazepines have been more selective hypnotic with less residual effects than the long-acting benzodiazepines. Benzodiazepines interact with the GABA A receptors, increasing the conductance to the chloride and therefore hyperpolarizing the neurons. Um, there are many different benzodiazepines with variable half-lives depending on their metabolism. This becomes important when using long half-life medications, since residual effects with impairment of daytime functioning may occur, especially in elderly, leading to an increased risk of falls and hip fractures. Another important concern in elderly cancer patients is the potential of benzodiazepines to cause delirium, cognitive impairment, and respiratory depression when combined with opioids. This is a big thing in United States. Is this benzo opioid combinations here because it's been shown to cause respiratory depression. So we gotta be very careful when we prescribe opioids and benzos together. In this situation, it's better to avoid benzos. Okay, so commonly used hypnotic drugs. We have ultra short acting, we have short onset brief duration, we have short onset uh, intermediate duration, we have intermediate onset duration. So the ultra short is like Zeliplon, short onset brief duration, triazolam, short onset intermediate duration of action is zolpidem, zoplicon, and isopriclone. These are basically the most important ones that we use for sleep disorders. These are more selective than the rest of the benzodiazepines as far as helping with with the insomnia without affecting other parts of your body here, like muscle relaxation, amnesia, uh, and all that stuff. And then you have the regular benzos, diazepam, clonazepam, and diazepam. It's really not recommended to use these, as an initial type of medication. Then you have non-FDA approved drugs for sleep. Uh, you know, and basically we do this all the time. Um, like amitriptyline, doxepin, trazodone, mirtazapine, and others like olanzapine, for example, quetiapine. I want to say that the commonest one we use in pain management, like off-label drug for insomnia, is trazodone, and the commonest one we use in palliative setting is mirtazapine. Okay, but you still can use small dose olanzapine, for example, or quetiapine to help with your sleep, especially if you have agitation. The most commonly prescribed benzos are the most commonly abused, and we talked about different medications here, like triazolam, temazepam, chlordiazepoxide, Librium, diazepam, clinazepam, alprazolam, lorazepam. Pharmacologic interventions. Antidepressant medications with sedative properties such as trazodone, amitriptyline, and doxepin can be beneficial for depressed patients with sleeping disorders. Side effects associated with antidepressants include orthostasis, particularly with trazodone, anticholinergic activity, nausea, constipation should be considered before prescribing these medications to cancer patients. Tricyclic antidepressants can decrease the sleep latency and reduce the awakenings and increase the sleep quality, but may also can cause concerning side effects such as daytime sedation, an anticholinergic effect, and cardiovascular problems, especially in older patients. Mirtazapine is a good option for managing multiple distressing symptoms in cancer patients. A noradrenergic and specific serotonergic antidepressant with antagonist activity on 5-hydroxytryptamine 2 and 3 receptors, mirtazapine can improve nausea, vomiting, and insomnia. An advantageous side effect associated with mirtazapine is weight gain because this agent increases appetite and thus improves anorexia in cancer patients. But by the way, mirtazapine is not in the current recommendation for cachexia anexia syndrome, uh, according to the ASCO 2020. But still, I mean, we know that for fact it does help with the appetite and uh, in anorexic patients. Amitriptyline is a tricyclic antidepressant. We use basically a dose somewhere between 10 to 25 milligrams. Okay? Uh, Amitriptyline helps also with neuropathic pain. So if you have a patient with neuropathic pain and sleep disorder, that would be a good choice. All right? Be careful not to go too high with this medication because it has many side effects by blocking like the histaminic receptors, the cholinergic receptors, and others. And it can prolong the QT interval. Trazodone, as I said, this is the commonest drug used in the United States for off-label use for sleep disorders in chronic pain patients. Um, it's a great medication, helps with sleep. Uh, I mean, very rarely can cause priapism. Um, I also don't go beyond 50. I mean, maximum dose 100 milligram at night. Mirtazapine, that's our antidepressant of choice in palliative setting because of its multiple, favorable, actions. It can help with sleep and helps with appetite, helps with, even with, breathlessness. Uh, so it's really a good adjunct, in palliative. Of course, it helps also with mood. Usually, we start with 7.5 milligram, and then we escalate later on to 15 milligram. Silanor or doxepin tablets. This has been approved for sleep. Doxepin is another tricyclic antidepressant, but it doesn't have the same side effects like amitriptyline. It's less, um, you know, um, I mean, it has less side effects because it doesn't cause, doesn't block these receptors that we talked about, like the cholinergic and histaminic receptors and others, the same potency like amitriptyline. So it's a good drug, as far as we're concerned, to most patients here. And basically, you have two uh, concentrations. You have the 3 and you have the 6 milligram. So obviously, you will start with the 3 milligram. Pharmacologic interventions. Um, the commonest drug used as over-the-counter for sleep is diphenhydramine, which is considered as an antihistaminic drug with sedative properties. However, diphenhydramine has its anticholinergic side effects like dry mouth. It can impair the cognitive function. It can, if you overdose, you can get delirium from it. The rapid development of tolerance and lack of safety data in palliative care patients should discourage their widespread use, particularly in the palliative care context. So this is not something really you need to utilize in palliative setting. Melatonin is a naturally existing hormone produced in the pineal gland, regulates the circadian rhythm by regulating the suprachiasmatic nucleus of the hypothalamus through the G protein coupled receptors from M1 to M3. The use of the melatonin in the treatment of sleep disorder is still controversial. So melatonin is used mainly, guys, for patients that suffering from circadian rhythm disorder. I mean, probably it will not be beneficial in other circumstances. Um, One of the suggested reasons for melatonin failure to achieve results against insomnia in clinical trials is the lack of consistency in the melatonin presentation, which might lead to the development of a specific melatonin agonist that have received FDA approval for treatment of insomnia. An example is Ramiltion, a selective melatonin receptor agonist that can potentially be helpful in patients with sleep onset problems or sleep phase disruption. Ramiltion does, however, have an important drug to drug interaction that should be carefully considered, especially in palliative care setting, whom they have a number, they're usually on a number of different agents. It's metabolized by the CYP1A2 pathway. Thus, it shouldn't be co-administered with other potent inhibitors of this pathway, such as Cipro and fluvoxamine. Because of the lack of conclusive data for melatonin use in the cancer population, the routine use of this supplement or its agonist cannot be recommended, even though melatonin appears to be very safe with few side effects. Diphenhydramine, again, we do not recommend diphenhydramine in palliative care patients, but I had to raise the awareness because this is the commonest over-the-counter drug used for sleep. Melatonin also is not recommended in advanced cancer patients and palliative care setting. But again, it's one of these commonly used drugs. This one is FDA approved for sleep, but again, it has no place in palliative. But in a regular setting, patient with a sleep disorder, that would be a good choice. Ramiltion or Rosarim. Okay. Other pharmacologic interventions, I like this one here, valerian. It's an herb and very commonly used in Germany, and it's over the counter. Okay. Unfortunately, the valerian can cause central nervous system depression and should be not used with other depressants such as alcohol or benzodiazepines, barbiturates, opiates, or other drugs such as antihistaminics, for example. It's unregulated product. and thus the concentration, the contents, and the potential contaminants in valerian preparations cannot be easily determined. Because of this uncertainty and the potential for toxicity in the fetus and hepatotoxicity in the mother, valerian use is discouraged during pregnancy. Headache and diarrhea have occurred among subjects using valerian in clinical settings. Valerian, 500 milligram per serving, and this is the valerian root itself. Multimodal intervention. In patients with advanced cancer due to multi-dimensional nature of the sleep disorders, including sleep quality disturbance, it's unlikely that sleep disturbance can be effectively treated by using a single intervention. It's similar to pain management here, guys. You know, not one agent can do the job, and thus you need to do multimodal intervention here or multimodal approach. And this is basically because of the complexity of sleep disorder. And there's been some evidence that combining different treatments could be very helpful, in treating sleep disorders. Like combining bright light with melatonin with CBT, for example. Okay, so we're gonna wrap up things here. Key learning points. Sleep disorders have a negative effect on the quality of life in advanced cancer patients. Fatigue, impaired daytime functioning, and mood disturbances are commonly reported in this population and could be secondary to sleep disorders. Both subjective and objective screening tools are available for evaluation of sleeping disorder in the cancer population. Interventions that are aimed at improving sleep disorders help alleviate these symptoms and increase the coping capacity. Management of these symptoms usually requires a multimodal approach with the use of non-pharmacological and pharmacological measures to obtain long-term results. Thank you so much.